I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin, and I'm thrilled to be joined by Dr. Gilles Dreyfus, a good friend, a colleague, somebody who's really educated me.
Oh, come on.
And you're going to be grateful that I'm not going to ask you about tricuspid regurgitation.
This is for sure.
We know it's bad. Okay, I don't have to ask you about it.
So we know, both of us.
We know it's bad.
They don't.
They don't. I like that. So tell me a little bit about resection versus non-resection for primary mitral regurgitation.
Yeah, I think that, until Patrick Perrier he published his respect rather than resect, right, which I think is a very good motto. But I mean, medicine is not advertising like selling toothpaste. Right. And I think that really the motto is clever, but behind this motto, there are a series of patients where there is some resection, because if you have a posterior leaflet with excess width, you need to resect. If you want to address the excess height of the leaflet by pulling the leaflet into the ventricle and increasing the height of coaptation height, it's one way to approach it. I would say that I'm still a bit puzzled that why he does have still 2 or 3% of SAM by doing so, because normally he should not have.
Right.
Because SAM is, again, I think we need to stand firm on a few definitions, but SAM, everybody talks about SAM. It's not the ring, it's not supple band versus complete rings. It's the height of posterior leaflet, which is in excess. Right. So if he does have some, there is a trouble with the technique, and this is in the master's hand. What I think is that we looked as well back into a personal series of 400 mitrals, degenerative mitrals, in a longitudinal study, and we saw that in 18% of the cases we did not resect. These cases most likely are represented by fibroelastic deficiencies, where you have a ruptured cord A, and then you just can fix it with an artificial cord and put a ring, it's fine, no resection. So we don't resect for the sake of resecting. We resect because we think that we need to reduce the size of the leaflets. And again, we have to come back to the basics, which are that if you have a chronic mitral regurgitation, you have an excess tissue. We all agree. There's a billowing part, a component of all the leaflets. Now, if you have an excess tissue, the tension, like on a sail, depends on the surface. The bigger the surface, the bigger the tension. So then you will have, most likely, if you leave too much excess tissue, you will have at a certain stage a higher recurrence rate of mitral regurgitation. This has never been studied, but I mean, if you look at the physiology of mitral regurgitation. So I don't think resection is bad. What was bad is probably excess resection, putting the tissues under tension. But I don't think that we should condemn doing resecting excess leaflet tissue. So now there is also a trend to say that if you resect too much, if you have resected too much, you cannot restore the tissue you have resected. Well, this is all about the learning curve. Now, there's another thing now which also pushes in favor of non-resection is the minimally invasive business. Yeah. Now, I really, very frankly, as a surgeon, think that the debate is over with percutaneous technology.
So I think now, what the debate of
the debate of sternotomy versus minimally invasive. So I think that the patients, what they care is, are they going to be operated, or will they have just a puncture under local anesthesia, no scar? Because whatever the size of the wound, you have all the complications of surgery. Even if my minimally invasive, and this is not honest.
You're talking about durability, is what you're really
I'm talking about. First of all, I'm talking about the pain, inflammation,
I understand
pneumothorax, hemothorax, whatever it have. And then second.
So you think that open sternotomy of whatever size?
No, well, if you want to do a small incision of the skin so the patient is happy, it's fine. I did some robotic surgery, and I still am doing. So I'm talking about something I know. It's not that I'm against it, You have to do it because some young patients, funny enough, the younger the patient, the greater the benefit of minimally invasive. So they go back to work quicker.
Right.
On the contrary, I think the old patients with a lot of risk factors or more risk factors, they don't tend to benefit so much of minimally invasive surgery because they have all the side complications. But truly today, we are being challenged by percutaneous technology.
No doubt.
And percutaneous technology is truly the reference of minimally invasive because it is truly minimally invasive because you do just have a puncture, you do not have an incision, you do not have anesthesia, you don't have a wound, and no inflammation. Now, of course, in the long run, the aim is durability.
Correct. And cessation of MR and doing away with mitral regurgitation.
Cessation of MR, I think we have to be very careful because today the interventional cardiologists, whatever the technology they are using, their only aim is to suppress MR or decrease MR, irrespective of the pathophysiology. Whereas the surgeons tend to have, with the time, which they have learned over years and years, they know about physiopathology. Now, when I hear the minimally invasive surgeons trying to oversimplify mitral repair, it seems that they are getting closer to the interventional cardiologists. The aim is to suppress regurgitation. And then we had this debate this morning when Volkmar Falk said that basically the surgeons have been unable to provide good results of surgery compared to a non-treated patients or compared with another option. So we've been failing with this. And in a few years' time, less than 5 years, the cardiological community was able to put up prospective randomized trials where they were able to demonstrate efficacy and the results. So this is really a failure of surgery over interventional cardiology. And I think that a lot of surgeons today are still having this disease, which is to produce results about what they think is right, but without any data. They don't have data. And so all the big series, Cleveland Clinic, Mayo Clinic, Dr. Adams, Germany, even mine, they are with resection. There are very few long-term results without resection.
Without resection.
And I would like to know the true results.
So you make the point, I think in closing, you make the point that resection takes away the pathologic tissue and could minimize the stress on the valve and the subvalvular apparatus.
Exactly. I think so.
Good.
And again, I'm not radically in favor of resection at any cost.
Right.
You resect if you need to.
Right.
Similarly to Perrier, who says that he does not resect, but he does resect in about 30 to 50% of the cases. He tends to minimize that, but the problem is that the truth sits there. You need to resect when you have too much tissue.
But what you're saying is that you want to reestablish good coaptation and as normal of anatomic and physiologic structure of the valve.
Well, what we have to do is restore a good surface of coaptation.
That's what,
Then is it anatomic? Probably not. Physiologic? Yes, the posterior sometimes doesn't move. Is it the ring? Is it the resection? I don't think his posterior leaflet pulled down by Gore-Tex cords is moving either. So I don't think we need to we're not trying to. A bird flies with his wings, and the wings go like this. An airplane doesn't go like this, right? And it works very well. So, I mean, we probably shouldn't mimic what a normal valve is. We need to restore a surface of coaptation. This is the key. Evenly distributed, and virtually you should not see or see very little posterior leaflet. And the whole thing is the whole role of the closure opening is like the door and the hinge of the door, and the ring and the posterior leaflet are most likely a hinge, and the anterior leaflet is the door. It's not perfect.
But I've learned a lot. We didn't talk about tricuspid regurgitation.
Oh, please.
I learned a lot. But I think it's a very clear and concise message. Thank you.
Thank you very much. It's always a pleasure.
It's always a pleasure. Thank you for joining us.